Hello, and welcome back to another episode of Age Better, where each week we take a deep dive into all the ways we can feel better, look better, live better, and age better. I'm your host, Barbara Hannah Grufferman. May is Women's Health Month, so I've been doing this special 4-part series dedicated to all aspects of midlife women's health, and I hope you're enjoying them so far. In episodes 1 and 2, we tackled essential topics like bone health and heart health, exploring how these critical areas can affect your well-being as you get older. If you missed those insightful discussions with incredible experts, be sure to check them out in the show notes. And I want to give you a heads up about next week's episode when we dive into the world of supplements. My guest will be sports nutritionist and New York Times best-selling co-author of The Whole Body Reset, Heidi Skolnick, who has been on the show several times. We're going to do a thorough review of some supplements that you might want to consider to age better and which ones you can probably skip. Okay, so let's get to this week's episode, which is part 3 of the series, and we will go deep into a subject that touches the lives of over half the world's population. Yeah, all women, yet often remain shrouded in mystery, menopause. To guide us through this complex topic, I'm joined by 2 esteemed specialists, Dr. Lila Nachtigall and her daughter, Dr. Margaret Nachtigall. Here's a bit about these 2 very special women. Dr. Lila Nachtigall, a true pioneer in the study of hormone therapy, estrogen, and menopause, has an astounding record of over 500 peer-reviewed articles, has written 3 books, and continues to lecture worldwide. Dr. Lila has shaped the course of women's health through her role as a professor at NYU School of Medicine and beyond. Dr. Margaret Nachtigall is a clinical associate professor at NYU Langone Health. She's not only a leader in women's health with her extensive work in polycystic ovarian syndrome, infertility, and menopause, but also a trusted voice where she educates and empowers women across the country. Dr. Nachtigall is also the medical director of Menopause Cheat Sheet, a newsletter we publish together, and she's a frequent guest on Age Better. Both Doctors Nachtigall are founding members of the Menopause Society, which until recently was known as the North American Menopause Society. Listen, it is unbelievable to me and to my guests that menopause is still so deeply misunderstood by not only women, but by the medical community. There are not enough doctors who focus on menopause, putting women at a true disadvantage and even at risk when it comes to managing their symptoms and their long-term health. As you'll hear in a few minutes, one of the most misunderstood symptoms of menopause is also one of the most common, hot flashes. So we decided to focus on hot flashes today, what they are, how they can be treated. But the most important part of this conversation, I think, is why we need to reframe how we look at hot flashes. They can continue for many years, and they can also wreak havoc with your heart and brain, which is why we want you to listen to this episode, even if you are postmenopausal like me, because it's never too late to take action. So pop in your earbuds, go out for a nice heart-healthy walk, and get ready to take charge of your health right now. Stay tuned. Joining me today are Dr. Lila Nachtigall, a world-renowned expert on menopause, and her daughter, Dr. Margaret Nachtigall, who is a reproductive endocrinologist and also an expert on menopause and a frequent guest on Age Better podcast. So welcome back, Dr. Lila, Dr. Margaret.
Thank you, Barbara.
So this is part 3 of a 4-part series focusing on midlife women's health because May is Women's Health Month. So it's the perfect opportunity to talk about this topic, which affects more than half the world's population. So, Dr. Margaret, new research has come out in recent years about how hot flashes, a common symptom of perimenopause and menopause, which can actually linger for many, many years, too many years for many women, are not just annoying, but they can impact your health in very serious ways. So please, Dr. Margaret, explain what is a hot flash and why do you think women need to spend more time focusing on them?
Great question. So just as you mentioned, hot flushes are one of the most common symptom that occurs in perimenopause and particularly menopause. And we know that a hot flush, which can be called hot flashes, is basically the feeling of being extremely warm. Some people, it starts at the head and works down to the toes, sometimes the other direction. You can get red and sweating, and it lasts for a short period of time, and then it is gone. And some individuals in menopause could get up to 20, 30 hot flushes a day, some fewer than that. And this can, although the majority of people, it lasts for about 5 years, it can last as long as 20 and even 30 years after menopause. Why does a hot flush happen? A hot flush comes because we know that estrogen actually keeps part of the brain suppressed. And that part of the brain is called the part of the brain that controls the thermoregulatory zone. So that means that this part of the brain is keeping us comfortable at a nice temperature. And when a person is deprived of estrogen, this part of the brain starts firing. And instead of being comfortable at this wide range, that range narrows. And so you're hot at a lower temperature and you're actually cold at a higher temperature. So both extremes can happen, shivering and sweating. We now know that that part of the brain, there are certain neurons called candy neurons. And one of those is kisspeptin, another one is neurokinin 3, and another one is dynorphin. The great thing and some novel approaches now is though we can actually modulate those candy neurons and mitigate or lessen or even eliminate hot flushes without using estrogen. But estrogen is what is keeping these at bay. So that's what a hot flush is. But the second part of the question that you asked me is, why would we want to treat it? Well, number one, you want to treat it because it can be very uncomfortable. It can keep you up at night, and we know that lack of sleep can be a serious problem. It's uncomfortable because it may interfere with your entire day's activity. You may be lecturing, you may be at a big meeting, you may even just be at your desk. Whatever you are, these are not comfortable. But in addition, it's very interesting that we have found multiple studies have shown that increased hot flushes, the more hot flushes we have, an increase in cardiovascular disease and an increase in dementia. Now, we do not know that one causes the other, but it certainly is interesting that an increase, there's an association. The more hot flushes, the more cardiovascular disease, and the more dementia. So treating it, we would imagine, would hopefully be able to decrease cardiovascular disease and decrease dementia.
Thank you. And Dr. Lila, you recently gave a talk at the American College of Physicians annual meeting about new treatments to manage these hot flashes that clearly, Dr. Margaret, thank you for explaining that to us, need to be treated. Please talk us through all the key options that are available to women at this time.
Well, for very many years, we knew that we needed estrogen to stop the hot flashes, even way before we knew about the candy neurons and the fact that estrogen is suppressing them. We knew replacing estrogen in the menopausal woman would treat those hot flushes and could. And we have to say, even with all the new information we have, we still feel that for the menopausal woman, when you want to stop the hot flashes, the gold standard is still estrogen. But we now have some very good long-term results from the WHI. And you remember that the WHI, I'm sure the women listening remember that was over 20 years ago and made it sound like estrogen was a negative. Well, following women for all these years, it turned out that estrogen was not a negative. When we look at long-term risks and benefits, the benefits of estrogen far outweigh the risks. But the real problem was the progestin. So women with a uterus who have to take a progestin along with estrogen to protect the lining of the uterus from hyperproliferation, which we know for a very long time. But the progestin was the bad. And the good news is we now have a great substitute for progestin. It's called basodoxifene, and it's only available in combination with an estrogen in a new drug, fairly new drug that's been approved by the FDA. And this combination is really working very well, gives you the estrogen, but protects the lining of the uterus without the negatives of progestin. So that's one new drug that I talked about to the internists who are finally getting around to treating menopausal women. But the other interesting fact is once we knew about the candy neurons that Margaret talked about, particularly the most active one in upsetting the whole balance of temperature called neurokinin, they were able to develop an antigen to the neurokinin, an actual suppressor specifically of the neurokinin receptor. And it works. And it has gone through all the phase 1, 2, and 3 studies. And almost a year ago, it was approved by the FDA, and it's now on the market. Its name is Fezolinetant, and it's marketed as Veoza. I think you all heard Veoza because the company is advertising quite a lot because they want to get the word out that there is an approved non-hormonal treatment for hot flushes. It doesn't do any of the other good things that estrogen does, such as treat bone strength or treat vaginal dryness, but it does really fix hot flashes, decreases their number, decreases their intensity, and works very well. And it also doesn't have any of the negatives of estrogen, doesn't stimulate the endometrium at all, doesn't cause bleeding. And it is available. It's nice to have this choice.
That's wonderful. And of course, as Dr. Margaret said earlier, treating hot flashes in partnership with your healthcare provider, of course, is really a very important thing for women to do, certainly to have that conversation. Dr. Lila, what is the best time? A lot of women want to know this, best time to start hormone therapy. And many women want to know if they can continue to stay on hormone therapy if they've been on it for a while, maybe somebody who's 65 or 70. I mean, is there a time frame here? What do you say?
Yes, there's definitely a time. So starting, I don't think you ever should start hormone therapy, what we call replacement therapy, before the actual menopause. But I don't think you have to wait for the definition of menopause, which is a year without menstrual therapy. If you're having symptoms and you're 2 months without a menstrual period, there are tests, blood tests that would show you that you're in real menopause. And with a lot of the new information, particularly about preventing dementia, which we all want to do, whatever we can do, the sooner into menopause you start, the better. So that's one point. But the other point that you're bringing up is how long can you stay? And, we are saying do not start if you're more than 10 years after your last menstrual period. And that's for a very good reason, because women that far away from making estrogen have a greater incidence of forming plaque. And if they have plaque, in their arteries, estrogen might make unstable plaque and it could travel. So that's when you get the risk of, say, a stroke.
Mm-hmm.
But when you're before 10 years, you don't. Usually estrogen is such a good protector of making plaque that these women are safe.
Mm-hmm.
The other issue is we say over 60 for the same reason, don't start estrogen. But if you started estrogen when you were 54 or 55 because you were recently menopausal, you can stay on it over 60 because the plaque formation is prevented. I mean, if you're still symptomatic, that really has to be reevaluated at least once a year
Mm-hmm.
to see if you still need it, to see if you can actually lower your dose now that you're older. And that's what we do when you go. But as Dr. Margaret said, there are women who still have hot flushes at 75, at 80, and when you go off medication, we put them right back on medication.
Now, is this time frame also true for the newer medications that are non-estrogen medications?
That's an awfully good question, but we don't know the answer to that because so far the studies have only been as long as almost 4 years of study. But that is definitely not enough to know that.
Mm-hmm. So stay tuned on that.
Stay tuned on that, but they do seem very safe. They have very few side effects.
Mm-hmm.
If you have abnormal liver function tests, it's not recommended to start these drugs. But other than that, these drugs seem very safe. They had very few side effects. It's not recommended if you have abnormal liver function tests, probably not to start any drug, but this is one that you don't start. But once you're on it, we do test for liver function at 3 months, 6 months, and 9 months. But once you have no change in your liver function after 9 months, you can go on with it. It's not going to be a problem. And we'll see, but I think that long-term use of this will be fine.
Oh, that's wonderful and very good news, I think, for a lot of people out there who are considering this new medication, but also who are currently on HT and are wondering if it's okay to stay on. So thank you for that. And we already talked about the window of opportunity, as I like to call it, which you both know because I've discussed it with each of you separately, but I aged out of that window and it is a regret. I have very few regrets in life, and that happens to be a regret, unfortunately. So that is not an option for me. But if someone has aged out of that window 5 to 7 years after menopause, but are still having symptoms and might be showing indication of bone loss and other issues connected to menopause, like maybe plaque buildup or maybe brain fog and the like, everything we've talked about, can a woman start hormone therapy later in life? But you already talked about that, which I think was very, very clear. So I think that the real message for this is that women should really have this discussion with their trusted healthcare provider and talk about the options and see if they are a candidate for hormone therapy. And if not, let's explore the other options that are out there. Because which is like our mantra, Dr. Margaret, whenever you're on, right? No woman should ever suffer.
Well, I think that's the big thing, is that since there is a window, as you said, a window of opportunity, is that have that conversation sooner rather than later. So right at the time of menopause or even a little bit before, to have the conversation so that you're well informed and ready to make that type of decision when the time comes. And, you might not know at that time what your symptoms are going to be. So you may have a very different feeling about it. And I have this conversation with patients all the time. And we go through all the advantages and the disadvantages, not only in general, but also as it pertains to that particular individual. Because everyone's coming in with a different set of pre-existing conditions, such as their lipid level? What is their cholesterol like? What is their family history? What's their family history of bone loss? Do they themselves have bone loss? Have they had a very sedentary life? Are they an exerciser? So all of these things are going to weigh into our decision. What's the cancer history, et cetera. So one is having that conversation, going over the pluses and the minuses as early as possible, because just as we have discussed, you really, if you're going to start, you want to start as soon as possible. And certainly not within the first 5 years would be ideal, not beyond 10 years and lower than the age of 60. But then you could stay on. We're not putting a time limit as to how long you have to stay on. You just keep reevaluating and you can stay on. Sometimes that new information, which is start within 10 years or before age 60, gets confused. And patients as well as doctors might think, oh, as soon as I turn 60, I have to go off my estrogen. That's not true. You don't turn 60 and have to go off. That might be only 3 years that you've been on. You're going to reevaluate, see if it's still important. You might want to start lowering the dose at that time and see if your symptoms come back. If you do, you can go back up in the dose. But the other conversation is also, if you are going to be on hormone therapy, what type? Are you going to go on a patch? Are you going to go on a pill, a cream, a gel, etc.? So there's lots of decisions to discuss, think about, and try, and options to change. But just as you said, the important thing is not to start when it's beyond 10 years.
I know you're very interested in the bone issues for women. Is that the first 3 years after menopause will be the greatest percentage of bone loss any woman will have. We know that. So whether she loses a lot over her lifetime or she loses very little over her lifetime, the greatest percentage of that loss will be the first 3 years after menopause. So I believe, and I think at least for that early time, it's the most important drug to protect your bone. That internists haven't been looking at that. And I think it was the WHI that threw them off. They used to use it right away. And it is the best drug for bone protection early post-menopause, even if for some reason you don't want to continue it after the first couple of years, you might change to a different product for your bone. And we do have a lot of choice there. But
right. That's true.
Certainly the best treatment for early on.
For early on. But it just seems to me that, and I hear this from so many women, that the whole idea of the discussion around hormone therapy comes up really more when a woman is experiencing the hot flashes and the more common symptoms, and doesn't really come up if it's like you feel great, no hot flashes or very few, but yet your bones are going to get weaker. And that just doesn't seem to be a focus. And that's really heartbreaking to me because you're right. I do focus on bone health a great deal. And we know the statistics around bone health. So I feel like I'm almost on a mission to get more people in the medical community as well as women to speak up for themselves and advocate for themselves when they're having these discussions. Like, no, my hot flashes are pretty manageable, but I'm worried about my bones.
Right. Well,
those are the discussions I think women should have more of.
I have to say it is increasing. And I do notice on a day-to-day basis that I see more patients coming in wanting to talk about hormone therapy than I have in the past. So I think there is an increased awareness, and with you talking about it all the time, more people will also request it.
That's great. Good news all around. Well, Dr. Lila, Dr. Margaret, you are both incredible. I so appreciate your spending time with me again out of your very, very busy days and busy schedule. But before we let you go, can you please share what you think are 3 key takeaways you really want the Age Better audience to remember from this talk today?
Well, for number 1, first of all, thank you for having us. Always fun to be here with you. And we love getting to be together. So that's a bonus. So that's fun. So I think the big things are individualized care and really to pay attention to yourself and what your needs, wishes, goals of treatment are. I think that just as we described, that there are many options now, both hormonal and non-hormonal for hot flushes, and that it doesn't have to be a hormonal option. And that if you are going to start hormone therapy, that there is that window that you want to start younger than age 60 within 10 years of menopause and to continually to reevaluate. That's 2. You have 1?
I thought you gave 3.
Did I give 3? Okay, great.
They were perfect. Oh, thank you both so very much. And everyone, please remember next week, we're going to have an episode focused on supplements, the ones that we think you might want to consider once you're in midlife, and then those that you should just say, nah, I think I'm going to walk away from those and save a little money. Okay, so we're going to take a deep dive into that. Thank you all again for listening. Dr. Lila, Dr. Margaret, thank you so much. Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this. We can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.